For repeated movement testing, it's an algorithm and it's cause and effect, but it's more nuanced than just, a patient buying Treat Your Own Neck and doing self-assessment at home. That will help a lot of people. But as a clinician, it's my job to understand the finer details of the testing process. After all, testing is what informs the diagnosis, and the diagnosis informs the treatment. So we have to be off to the right start, off on the right foot. So I've elected here, just for an example, to use the movement of neck retraction. And of course, we have to further specify, is that in the load of sitting, supine, prone? Is it neck retraction with clinician mobilization, with patient overpressure, etc.? But in this example, let's just say neck retraction. Let's say that the person has left neck pain in sitting, so that's the present symptom. The next column, and there's only a few, the next column is during the motion, what happens? So the patient performs cervical retraction. What happens to that left neck pain? Does it go away? Does it get better? Does it move to the center? Does it start zinging pain into the shoulder? Does it momentarily produce numbness and tingling in the left hand? Does it create right neck pain? All of those things, I want to know what happens during the exercise. And there are specific words we use in repeated movement testing as put forward by Robin McKenzie when he developed this type of test for orthopedics, such as produce or abolish or decrease or increase or centralize or peripheralize. But the layperson can kind of get an understanding of what's happening when you do it. When you push back into this position, what happens as you do it? And then in this column, I'm also noting, if I don't write it down specifically, I'm noting in my head, and I'm usually verbalizing the question to the patient, what happens the more you do? That really is an important piece of the puzzle for me as well. For example, retraction for the neck, if the left neck pain is increasing each time you do it, but the more you do, by number 8, number 9, number 10, it's not increasing as much or it's getting better, that's important. These are not, again, diagnostic. We haven't even gotten to the after section yet, but we want to know because it can give me a clue as to what may be helpful. For example, if cervical retraction, every time you do it, by number 8, number 9, we go up to number 20, for example, each time you do it, it's really lighting up the arm. Well, there's just less likelihood that this is really the movement that you need. But if every time you do that retraction and that left neck pain turns off when you're in that position, so you have left neck pain in sitting, you go into retraction and momentarily turns off until you come out of it a second later, that gives me more credibility that this movement is worth exploring. It's not entirely, but it's just weighing the balance. It's telling me something, not everything. So if it's reducing symptoms or centralizing symptoms during the process, that's likely a good thing. If it's increasing pain, if it's peripheralizing, that's likely not a good thing. But we don't know until the after. There are a few times when I have to abandon a movement when we're testing it during the set. For example, by number 5 or number 6, it's clear that we're doing a movement and it's just really peripheralizing symptoms. The patient doesn't like it. Of course, we're going to see what the baselines are after, but I'll probably stop at number 5 or number 6 before making us finish the set. The set is an arbitrary number. I want the information. That's what I'm after. I'm not interested in what does 10 do to you. I'm interested in what does cervical retraction do to you. So in this during section, I'm using those words like, moves pain to the center or produces right shoulder pain, etc. And then after, that's what you're gleaning by asking the patient, okay, we've done those cervical retractions. Now we can get a symptom baseline and we can get a signs baseline. So the symptom baseline is what's happened to your pain. If the patient comes in without pain, well, then we're looking to see if we've produced pain. If the patient comes in with pain, we're looking to see if we've made it worse, we've made it better, we've abolished it, we've moved the position of the pain. Especially with spinal disorders, movement of pain can be really helpful in understanding what's going on, especially if it's centralizing or peripheralizing in an obvious manner. But the after then is going to be what's happened to symptoms after we've done the set and what happens to the mechanics. So any range of motion, any strength, any nerve tension, any functional baselines that were not good when we took the orthopedic baselines in part 2, we will retest. Now, if 8 things were problematic, maybe 4 ranges of motion were painful and or limited, there's nerve tension, it's painful doing several different things like bending over or reaching, I, in the name of time, will likely not do all 8 to retest them. I will also not usually do all of them because I don't want to keep provoking or irritating the problem. I choose the ones that I think are most important to really understand. So for example, if someone has a neck disorder, we think it's mechanical, or at least we're using repeated movement testing to see if it's a mechanical joint disorder that can be fixed with movement in 1 or 2 directions. If there's a discrepancy, maybe in rotation left and right or side bend left and right, I would want to check that again. Or if extension is moderately limited but flexion is mildly limited, I'll probably want to check extension more than flexion. But it depends. It depends on the presentation. I'm choosing based on my clinical decision making and judgment and time that we have, which baselines I want to recheck. But that's the crux of the after. What happened to your symptoms after? What happened to all those baselines, or the most important baselines that we found in part 2 of the orthopedic evaluation? And then if we're noticing that the more we do, the afters get better, range of motion is better or less painful or more range, nerve tension is better, functional movements are better, or strength is better. Maybe you had weakness with shoulder flexion, or maybe you had weakness in abduction. We can test those things and on the whole make a judgment. If we've done 10 or 20 or 30 cervical retractions and I'm seeing a decent amount of better, people always want to know exactly how much better, and I say on the whole about 30% minimum improvement in those 5 minutes of doing cervical retraction is what I'm looking for in order for me to think it's effective and worth our time to continue that repeated movement test at home. We're not going to get the answer after 10, 20, or 30 repetitions of cervical retraction, but we're going to get a really good answer after you've done it 100, 200, 300 times over the course of days up to a week. So that's where the decision making comes in. Do I think it's worth time to test this more? And for retraction, it's easy to do. It only takes a few seconds. But that 30% that I mentioned, it varies. If the patient's coming in with a 20-year history of a neck stiffness and neck pain disorder, I might not expect, or I usually won't expect to see a 30% change with 30 repetitions. But for someone who injured her neck sleeping in a wrong position a week ago, I would expect that. So it varies based on many clinical factors. But if I had to give you a number, I'm looking for something that is around the 30% ballpark, but more importantly, it's something that I'm not wishy-washy about. Like I can say to myself, yes, that range of motion is better. Yes, that nerve tension test of the upper extremity is better. And I really want the patient to also notice it, because if the patient notices that change, they're more likely to be on board with continuing that testing at home, and having the patient kind of agree that it's worth their time is often an important factor versus it just being something that I'm telling them to do. Most times, if we find that there's a movement that's helpful, the patient will observe it. And I don't want to have to point it out. I want them to know when I ask, is it worse, better, about the same? They say, oh, better. And for mechanical disorders that are straightforward, the person is going to be like, oh, it's definitely better. So that's kind of the nitty gritty of a repeated movement test. Now, if I do neck retraction and it's, making things worse and I abandon it, and either the during and we test and the after is worse or no effect, then we go on to the next repeated movement test. If this was in seated, maybe I'll do neck retraction in supine. Or if things are demonstrably worse with the repeating the tests from the baselines, I might go on to neck left side bend or neck extension or neck flexion. It really depends. And then of course, that's the understanding of repeated movement testing is people who are just attempting it at home, which is great. It's more of a trial and error system. But for a clinician, it's more about this told me something And so it tells me what to test next.